It is not about chasing size 0. It's about treating overweight or excess fat or obesity. Maybe I want one size less. So that's not recommended because that is unexplored. People in general view obesity as a cosmetic disorder. The challenge that we are facing is that when you use these drugs, patients lose weight. तो कहते हैं अब ज़रूरत क्या है कुछ करने की, तो ऐसे ही वेट कम हो रहा है, डॉक्टर साहब बेकार में आप एक्सरसाइज बोलते हो. It's about health and healthy weight loss. Whenever we lose weight, you will also lose muscle. And the problem there is, if you lose it and you put it back on, what you put back on is just fat. There is at least a 30% chance, 25-30% chance of nausea, episodes of diarrhea. You should walk in with your eyes open. There are 10 to 15% people who don't respond. Maybe they lose only 1 or 2 kilograms or 3 kilograms. There are other things. Every time you lose weight, you may get gallstones. Any drug that has an effect could have potential side effects. My only fear in this is standalone use of these drugs, inappropriate use of these drugs, people who don't need these drugs taking them and then giving them up. These are not over-the-counter drugs, not at all. These drugs only work as long as you use them. If you take somebody off the drugs, you go cold turkey, suddenly stop the drug, the weight will bounce back.
Hello and welcome to HT's weekly talk show, The Interview, and our special segment, Health with HT. GLP-1, Mounjaro, Ozempic and some other unpronounceable names. I will not even tread that path except to simply borrow the tagline, weight loss drugs and how to use them. What are these drugs and how do they work? When to take and when to stop? Who should take and who should keep away? What is thin outside and fat inside? What is the benefit versus risk calculation? And when and where to draw the red line? One could go on and on, but it is time to speak to Dr. Ambrish Mithal, a well-known endocrinologist turned author, whose recent book, The Weight Loss Revolution, is making news. We have him here with us as our guest in our weekly talk show, The Interview, and our special segment, Health with HT. Dr. Ambrish Mithal here with us today to talk about weight loss and the new drug which is making waves. Welcome to the show, Dr. Ambrish Mithal, and thank you for being here with us.
Thank you.
First, let me congratulate you on your new book on weight loss, which is making news.
Thank you.
Let me begin by clarifying your status, if I may use the term. Are you advocating these drugs as an endocrinologist or as a weight loss expert? Because I'm completely confused.
I think that's a great question, and it allows me to explain something very simply, and that is obesity is a part of endocrinology. But the issue is that there were no tools with the endocrine physician to deal with it. So either it was lifestyle and diet and exercise, or at one extreme end it was surgery. The excitement is because now endocrinologists have medication or tools to deal with the problem of weight or obesity. So there is no contradiction in this. Endocrinologists are the people who deal with this issue, especially if you start looking at obesity also as a disease like you do with diabetes.
But my impression was that a diabetic automatically lost weight, and maybe the metformin or the drugs led to automatic, as I said, weight loss. Is that right or is that a myth?
So yes, severely uncontrolled diabetes results in weight loss, unhealthy weight loss. That is a different story altogether. But if you were to look at preventing or treating diabetes, weight reduction is one of the most important strategies. In fact, just when people ask that I'm a pre-diabetic and I want to save myself from becoming a diabetic, or how should my kids not become diabetic, the single one-line answer is maintain their weight. And if a pre-diabetic doesn't want to become a diabetic, he or she has to lose significant weight to come within the sort of normal range, and you can prevent or delay diabetes by years and years. Weight reduction is a very important clinical parameter or clinical approach to managing diabetes. And I'll add one more line here. More than 80% of people with type 2 diabetes have excess fat. And if you reduce that excess fat significantly, you can reduce type 2 diabetes significantly.
You know, you said pre-diabetics
Yes.
need to lose weight.
Yes.
A pre-diabetic, in my understanding,
Yes.
is a normal non-patient.
Yes.
Why would he come to a doctor? So ultimately, when they come to you, they are diabetics.
So yes, in general, you're absolutely right. And this is moving the needle a little bit more and more towards perceived normal people. You're absolutely right. But pre-diabetics come to us a lot because it's found out in health checks. Of course, we are talking of a very small segment of the population who undergoes health checks regularly. There you would find that rising blood glucose means that there is a tendency towards diabetes, or people who come to the hospital for other things, for a surgery or for something else, and they get their test done. And that is a real solid window for intervention. Weight is the forerunner actually, and diabetes, typical type 2 diabetes, comes later.
What I am gathering is you would then recommend, if you would, that normal healthy people who go for health checkups or don't should actually do a pre-diabetic check.
Yes, I think almost certainly blood glucose is part of any testing now. I mean, and maybe an HbA1c also. So it would be in India very important for people to look at that, even starting the age of 20, definitely at 25, to screen for diabetes or for pre-diabetes. The age at onset of diabetes has progressively come down. And it's not unusual at all to find even teenagers who are developing type 2 diabetes.
I am not going to use the unpronounceable GLP-1 or Monjaro, etc., and I am going to simply say weight loss drugs.
Yes.
So let me ask you, are these drugs purely for diabetics or for those chasing a size 0? What is the primary focus?
So GLP-1 drugs have been around in clinical use since 2005, and they were developed for diabetes. Those molecules have been around. We are all very comfortable with them. But they also have another action. The same GLP-1 hormone goes to the brain also. In the brain, it has a very important role of telling us when to stop eating. Suppresses our appetite. So these drugs were designed originally for diabetes. But when they discovered that they could play with these molecules from the GLP-1 stable in a way that gradually the weight loss effect became very pronounced. And what has happened in 2018 or so, when the first one, semaglutide, got licensed, was the fact that scientists were able to achieve 15% weight loss. With the predecessors, weight loss was 4%, 5%. With metformin, it is 1-2%, So this was dramatic. There was never a drug that could achieve 15% weight loss, and then subsequently 18%, 20%, and now we are talking of 24%. So you've reached a zone where you can produce very meaningful weight loss, enough to reverse disease or treat disease of other kinds which happen because of the weight. So that is why the GLP-1 story, which started with diabetes, the weight effect caught the public imagination, and that's why no one talks of anti-diabetic drugs the way they do of anti-obesity drugs. That's the story you're hearing.
So in that sense, those chasing size 0 can go on these drugs irrespective of whether they are diabetic or not?
Yes, they can, but it is not about chasing size 0. It's about treating overweight or excess fat or obesity, whatever you call it. If you are healthy and your body weight is okay, don't have excess fat, you should not be attempting to use these drugs. And that's the biggest danger, because when the drugs are sort of have such attractive cosmetic property,
Yes.
people will be tempted to use them. Maybe I want one size less, so that's not recommended, because that is unexplored, and there the risk benefit ratio may not be so great. People in general view obesity as a cosmetic disorder.
Right.
Doctors, in particular endocrinologists, view obesity as a disease or a condition, and there is the sort of, sometimes there's a mismatch, and that can lead to complications.
Just explain this a little more, because what you said really resonates, because obesity is taken as cosmetic.
Yes.
And we don't think it is a disease.
Yes.
So just decode this for me.
So obesity, actually even the word is now disputed, because there's a stigma attached to calling someone obese. Therefore, some societies like the American Society, they now call it ABCD, adipocity based chronic disease, to avoid using the word obesity. Like in our prescriptions now, in my prescription, we don't write obesity. We have to think of this as a disease, because by itself it can cause major significant abnormalities, and it definitely promotes the development of diabetes, hypertension, heart disease, fatty liver. If you go beyond a particular weight, then your knees hurt, all kinds of arthritis play up. Even neoplastic disorders like some kinds of cancer can be promoted simply by obesity. So we have to think of obesity as something that needs to be fixed. That does not always mean that it has to be fixed by medication. So it should not be medicalization of normal people or relatively healthy people, but it does mean that it requires attention. If you are a little bit 2, 3, 5% overweight, not perfect, it doesn't matter, try diet, lifestyle. But if you are reaching a particular level where disease is beginning to happen and diet and lifestyle will not be enough, there we have tools now to treat them and bring that condition under control.
Is that the reason why you said that using these drugs for weight reduction, while you're using them, don't depend on these drugs completely?
Yeah. The challenge that we are facing is that when you use these drugs, patients lose weight, तो कहते हैं अब ज़रूरत क्या है कुछ करने की, तो ऐसे ही वेट कम हो रहा है, डॉक्टर साहब बेकार में आप एक्सरसाइज बोलते हो. What we have to understand is that it's about health and healthy weight loss. And if you want to have healthy weight loss, it is important that you improve your muscle function. It's important that you eat healthy, and that's when you get maximum benefit from these molecules. So they have to be part of a weight management program. It cannot be that you just take the drug and you're losing fat, you're not exercising, you're losing some muscle also, you're not looking after yourself. The moment you reach a stage when I say, okay, let's try and gradually reduce, everything will come back, because you haven't entered the lifestyle domain the way you should have.
You know, while talking of muscle loss, you have said that while using these drugs for weight loss, you will also lose muscle. So that is one side effect which is bad enough.
So I think that is the most talked about effect. But there's good news there. The good news is the drugs don't cause muscle loss. Whenever we lose weight, you will also lose muscle. So roughly 20%, some studies show 30% of the weight you lose is muscle. So if you lose, say 15 kilogram weight, you are one of those who lost 15 kg, maybe 4 kg might well be muscle. Well, that's huge. And the problem there is, if you lose it and you put it back on, what you put back on is just fat. So the muscle that is gone is gone. If you go through 3 or 4 of these cycles, you've lost a lot of muscle and the fat has all come back. So the drugs are not bad for the muscle at all, but we still have to prevent it, because such muscle loss wasn't happening except following bariatric. So strength training, which is the buzzword as you know in exercise, and adequate protein intake. Now, why is this important? Diet has suddenly gone down by 50% because you're taking these drugs. So the protein will also go down 50%. That is not acceptable at all. So ensure adequate protein and fiber and of course adequate hydration along with exercise will give you fantastic results with these drugs. And it will also enable you to become healthier in the long run and not just cosmetically losing weight.
What is the bad news?
The bad news, short term of course has to be understood. You should walk in with your eyes open. There's at least a 30% chance, 25-30% chance of nausea. If you include mild nausea, the chances are very high. So you have to be prepared for that. Some people get significant gut issues of other types, constipation, episodes of diarrhea. Some people said, "Doc, you told me all these things, nothing happened. I'm, fit as a fiddle." But there are others who say, "Well, I didn't expect it to be so bad." The key thing there is, A, to decide when is too much, and for that you will need your physician's help. Then the other is that not everyone responds. There are 10 to 15% people who don't respond. Maybe they lose only 1 or 2 kilograms or 3 kilograms. We of course don't use it in people who have a family history of thyroid cancer. Pancreatitis is the other buzzword. This whole group of drugs, which has been around for 20 years, very slightly increases the risk of pancreatitis. Ask your doctor if you have a history of pancreatitis, don't use them. There are other things. Every time you lose weight, you may get gallstones. The one issue that has been reported, exceedingly rare and not established yet, is other eye-related issues. So there is some signals appearing in the eye which we are not at all sure about yet, because one study will show a signal, other study will not show a signal. Large database analysis of thousands will show nothing. So but it's something that has been sort of flagged. So as an endocrinologist, we are all aware of that. Any drug that has an effect could have potential side effects. So there's no way one can say, "Oh yeah, that there's no side effect." It's not possible. We are learning about that, but I don't think anything dangerous or sinister will emerge, very unlikely, because we've been using the class of drugs for 20 years.
So hit and trial nahi hai?
No, this is not experimental. For example, oral form of Ozempic, we have been using for 3 years now, and we haven't found any such things with great confidence. But oral is less potent, but nevertheless it's a very good drug for diabetes. So
you said that nausea, vomiting, these are short-term side effects, and they will not stay and they will go.
Yes.
What is there to stay lifelong, adversely more?
To be very honest, there's nothing that I can say with any solidity that, yeah, this is something you'll be left with. My only fear in this is standalone use of these drugs, inappropriate use of these drugs, people who don't need these drugs taking them, not being careful, losing muscle, not exercising, and then ending up, and then giving them up randomly. That is, I am scared. I would not use them in people who are already on the frail side, or have very poor muscle mass and are older. I would be careful there.
Would you say then, or would you advise then, that these should not be off-the-counter consumption drugs and should only be consumed if recommended by a doctor?
I think that should be framed, that statement of yours, and hung everywhere in every obesity program, every clinic. These are not over-the-counter drugs, not at all. And in India, people try to find ways to procure anything, but I think we have to stick to the fact these drugs have to be prescribed by a recognized specialist or at least a recognized doctor, and they should be closely monitored. If they are used over the counter randomly, I foresee significant amount of problems that we will face with this medication.
As of now, are they available easily? Are they available without a prescription, or is prescription a must? What are the safeguards?
No, I think they are definitely prescription drugs. They are available all around now in all major pharmacies. The government has labeled them as prescription drugs, certainly not over the counter.
Okay, so that you see as a safeguard?
Yes, but it has to be implemented very strongly.
When you say prescription, I want to also understand a prescription from an endocrinologist is what is really the done thing, or any nutritionist, any dietitian can, who's chasing weight loss for their clients, I won't use the word patient, for their clients, can recommend and say, okay, take it irrespective of what the medical side effects adverse could be. And isn't that a red flag?
That is a fear, but the prescription has to be from a qualified medical doctor. It need not necessarily be from an endocrinologist, but a qualified medical doctor has to prescribe. What happens is when you use a drug indiscriminately for those who are not ideal candidates for the drug, and if you don't monitor carefully, then you get some side effects, and then the whole drug gets a bad name, and then when you have to use it for the right patient, then it becomes a challenge because the patient is scared.
Because my fear was that while this is a patient specific drug, whether it is obesity as a disease,
Yes.
and not cosmetic,
Yes.
and it is diabetes, people who are chasing size 0 and go to a dietitian, for instance, as a shortcut measure, could then recommend it irrespective of the medical, non-existent medical condition of that client.
Yes, and that is a fear. I really cannot deny that, but that's unfortunate, but it's possible.
Okay, talking of weight loss, is it also true that once you stop this drug, the weight gain happens as much as 70%? Maybe the figures are exaggerated or wrong or whatever, but the weight gain comes. So once you stop the drug, it's like a diet. You go on that regimen, you lose weight. Once you stop and go back to your normal lifestyle, you go back to what you were. Is that true? And that is one apprehension, that once you stop the drug, the weight gain happens.
You're right, absolutely. So what happens is that, like when we treat diabetes, when we treat thyroid conditions, treat blood pressure, these drugs only work as long as you use them. So there is a challenge that if you take somebody off the drugs, you go cold turkey, suddenly stop the drug, the weight will bounce back over a period of time, but it will come back. Therefore, there has to be a strategy there. One is that people who have diabetes, who are sort of midlife, and it's used as a medication, like diabetes medications go forever, insulin goes forever, they also go forever. See, when we lose weight, there is a weight loss phase and a weight maintenance phase. So,
and a weight gain phase.
And a weight gain phase, yes. So after the weight loss phase, we start de-escalating the medication gradually, so to reduce the load of medication. So someone, let's say, is on 15 milligram tirzepatide, you gradually bring in or her down to the lowest possible dose. That may allow a little bit weight gain, but nothing compared to what the weight loss has been. There's the trick now, where when you come down to the lowest possible dose, how to take it off. In some proportion of people who didn't have severe obesity to start with, you probably can take it off if they're really good with their lifestyle. But those who had severe obesity, it's unlikely that you'll be able to take it off. So when you again go into this plan, you have to go in with your eyes open about the duration. And what we explain typically is that be prepared for 1 to 2 years straight away. And if you think it's a 3-month course, no, it's not a 3-month course for weight loss. No, not recommended at all.
But it is time bound.
No, you can go with it forever.
But once you've lost that weight, then you will need to stop.
Then you need to bring it down lower
and then stop
and lower
gradually.
And maintain at the lowest possible. And if you're one of those who've done very well, maybe you can take it off. But there will be a significant number who will require a very small dose just to continue.
So it's a life companion?
In some cases it can be, like a diabetes drug or a blood pressure drug. Not in all, but in some cases definitely. In fact, I would say the sicker the person when we start it is very likely to require it, more likely that that person will require it forever.
Yes, but that weight gain question, how do you combat that challenge? Because you go off the drug at some point, maybe even after 3 years, and then you come back to what you were, or at least half of what you were.
Yes.
So what is your option and what is the way forward?
So the way forward is only lifestyle. I mean, there's nothing else you can do. Let me tell you one more thing. Yes, again, if you're saying we stop the drugs today, suddenly, then for sure. But if we do it very gently, very gradually, emphasizing lifestyle measures and gradually tapering the drug, then we will succeed in some people. Right? A lot, then the onus really lies on the person, individual, and a bit of it is luck. Let me tell you, this field is just opening up. There will be many options available which will be not so intrusive and not so difficult to use as we go down the line. And it is very possible in your and my lifetime, these will be like regular drugs.
So, since this field is just opening up, why not wait a little rather than put the people on what I would say experimental trials, in that sense, if you'll allow me to use that word. But why not wait? And then if you're talking of lifestyle changes, then why not start with that lifestyle changes, which is the conservative method, rather than go to the drug, lose weight and then do lifestyle? Why not the other way around?
So, you're absolutely right. It is always the other way around. You certainly will not start these drugs in someone who has made no lifestyle attempts. Lifestyle is the basis of all management of diabetes and obesity. That cannot change. The drugs come on top of that. But what research has shown and experience has shown over the years, that it's incredibly difficult for people to keep their weight down with just lifestyle. If you're at a BMI over 30 or 35, it is very hard to expect you to lose that kind of weight. I'm not being fair as your doctor. Okay, you go and lose 20 kilograms. How does the person lose? We have to give him more help or her more help.
Right. So, you go to these drugs.
Then we go to these drugs. You sit in my OPD one day and watch. I mean, it is crazy. People are so frustrated about their weight. It's not so easy. And that's why these drugs are a support. They're not a crutch, but they're a support to our lifestyle measures. And we suddenly have tools, not even suddenly, we have now those tools which can
which your book
help
has
our
made
patient,
popular.
Which can really help our patients.
What you're saying is that lifestyle, when that fails, go to the drug.
Correct.
You go to the drug for 2 or 3 years, you achieve
At least,
that.
at least 2 or 3 years. Yeah.
You achieve that.
Yes.
And then you go back to lifestyle.
So, lifestyle will continue throughout. Where
Right.
will that change?
Okay.
Yeah.
The lifestyle continues throughout, but then you take away the drug from your life, and then the lifestyle fails again, which is again where we come to the weight gain.
So, exactly. So, therefore, those who have significant obesity to begin with, very significant, and especially if they have diseases associated with obesity, they may have to remain on some dose of these medications forever. Now, the important part you asked, which I didn't answer, is experimenting. No, we are not experimenting with our patients. That's not correct. With every new drug that comes out, before it comes out, there are at least 2 decades of work, sometimes more than that, behind that. Yet there are some false starts. There are drugs that fall by the wayside because after approval you find there are problems. But by and large, that is not the case. And I will repeat here that this class of drugs we've been using for we have been using for 20 years. So, one is not really scared of any major long-term things. But yes, if it's going to be used by half the population, then we don't know what will emerge.
So, I think the problem is with the nomenclature. The moment you say weight loss, everyone wants that drug.
Yes. But that's how they become popular. Yeah.
That's right. When you say obesity, then I will stop and say, am I obese? Do I require it? Is it a disease? So, don't you think the nomenclature of weight loss drugs, which of course is the title of your book, is in one sense misleading? And we should really say, as you started by saying, obesity is a disease. So, if I am going to an obesity drug or a diabetic drug or anti-diabetic drug, I would say I don't need it because I am not in that realm. But when you say weight loss, everybody, like I was when you said there is a patient who came to you who said, I want to lose weight, and you said why, and she said because in college I was 40 or 50, and you
that
said
happens
but you,
every day.
Yes, but you're not in college now.
Yeah.
So then that segment who wants the college weight when they are middle aged would go to that drug.
Yeah. So I think that's where the discretion of the treating physician should come into play.
Or change in nomenclature.
Nomenclature is not weight loss drugs. Weight loss drugs became a nomenclature because public picked it up like that, New York Times picked it up like that, Oprah Winfrey picked it up like that. So the whole thing became a buzzword, and that's why they became popular. As I said, we get new anti-diabetic drugs every couple of years, but we don't get interviews like this for that. So it's the weight loss that is a buzzword. Yeah. So we are looking at overweight as a condition or disease that requires treatment. But you're absolutely right, the public doesn't look at it like that. And if you use the word weight loss, it catches the eye.
Absolutely. Yeah. Then it is for everybody.
Well, it's not for everybody. In a sense, people may interpret it like that. Yeah.
It is for, it's not then for those who are suffering a medical condition, but it is for those who are wanting to lose weight.
Well, you have a point. I mean, you're right.
Okay, so will you in your next edition change the title of your book?
No, this book is for the public. So I think the weight loss revolution is what it's called. So, and that's how people connect with it. If you write a drug about obesity, something, then people will say, I'm not obese, I'm not interested.
That's right. But that's the whole point of this drug.
No, but then there is a lot of gap between what we perceive as obese and what is actually excess fat. So in conventional terms, we think of someone who's fat as obese. But the truth is that many of us are in the intermediate zone where we do require treatment, but we are not overtly looking obese. And that is particularly true, as you know very well, of Indians, because Indians have that toffee kind of thing, that thin outside, fat inside.
I was just going to come to that, a term you've used in your book. So just explain that to me. What does it mean?
Cosmetically, many Indians might look fine. They may not look overweight. And even by standard BMI criteria, they will not be overweight or obese. But they still have excess fat inside around their viscera. And that is the bad fat. Not all fat is the same. So fat on the thighs or the shoulders or upper arms is different, is much less unhealthy than the fat that is around the viscera. So the visceral fat is the one that releases the bad guys, the bad toxins and the inflammatory cytokines, whatever. So therefore, we have to understand that many of us who in the public eye would not be called fat or obese,
thin outside,
but they actually are obese inside. They have excess fat and they are candidates for treatments. Therefore, if we start saying that this drug is just for obesity, we have to first make people understand, which I have tried to do in the book, that obesity is a disease and a condition not necessarily reflected by what we see. It's the inner fat that matters.
Dr. Mithal, you have explained a lot and I have tried to understand, but let me ask you to tick the boxes and maybe at the cost of repetition. Yes. In a nutshell, what are these drugs? How do they work? When to take, when to stop? Who should take and who should keep away? And what are the ifs and buts and the unknown and unexplored areas, the red flags, so to speak?
So if I answer all of that, no one's going to read my book.
Okay. Your publisher will kill me.
No, but tell me please, let's go bit by bit. What are these drugs? Okay.
And how do they work?
Drugs that mimic the action of a gut hormone called GLP-1, and they improve our diabetes control, but they also have many actions beyond diabetes, including a reduction in body fat. But very importantly, they have actions within people with diabetes and without diabetes to reduce the risk of heart attacks, to reduce the risk of progression of kidney disease, reduce fatty liver. So there are huge things that they do, many of which are simply related to fat reduction, but many of them could be anti-inflammatory actions of these molecules. That is what these drugs are.
When to take, when to stop?
So, at the moment, the guidelines are based on BMI. So if one has a BMI over 30, even if one does not have any other condition, one can be a candidate for these drugs after talking to the doctor.
Though you said BMI is not the only measure.
Yes, so in that case we will have to move the BMI lower, but we are being very conservative. So 30 and above is the Western criteria in India. Probably it will become lower over a period of time. And if you're of BMI above 27 and you have other diseases that go with fat, then you're a candidate.
When to stop?
When to stop is a challenge. We don't have a final answer, but there is definitely one category of people who will not stop it, who should not stop it. Those who are taking it for weight with clear diseases like diabetes, blood pressure, etc., they probably are candidates who will lead it throughout, because we are not just losing weight and controlling diabetes, we are also protecting their liver, their heart in particular, and kidney. For others who are taking it for just weight loss, one has to try, and one cannot promise that when you will be able to go off the drug. But a gentle tapering of the drug after weight loss has been achieved, whatever lowest possible dose can maintain the weight, or maybe even going off it if you can maintain the weight, is the way to go.
Ifs and buts, unexplored areas and the red flags.
I think any drug that has so many actions across the body as I enumerated will potentially have some areas which don't work in our favor. But at the moment, 20 years of work on these drugs has not really shown that.
Okay, let's discuss the costs, which are prohibitive, perhaps 17,000 per month, while metformin is very affordable.
Yes.
Aren't we then advocating a rich-poor divide?
Not really.
Okay.
Not really. I'll tell you why. Because these drugs are way beyond metformin. I'll stick my neck out and say that. Even for treating diabetes, these drugs are way beyond metformin. We don't have the data on heart outcomes, on kidney outcomes, on liver outcomes with metformin the way we have with these drugs. So we are looking at a far superior set of molecules. Metformin is a great drug. It's safe. It's been there for 5-6 decades and we've all used it. It remains the first line drug, but I expect that these drugs will replace metformin as first line drugs somewhere down the line. But the challenge is the cost. It's a challenge worldwide, not just in India. But that happens with every new drug. Yes, at the moment, if you ask me, 2025, July, yes, there is a rich-poor divide in the use of these drugs. But I don't think that's going to last. It hasn't lasted for any of the drugs. So I do expect down the line, maybe a year, 2 years, prices will crash. So I don't take that as a deterrent at the moment, because history tells us that all these drugs, they become much cheaper as time passes.
You know, in your introduction to the book, you've compared the side effects to buying a car, which despite the safety measures does not guarantee a no accident situation.
Yes.
Let me flip this to GLP-1 and assess the benefit versus risk calculation, to quote you.
Yes. So I think the benefits in this case, actually, Kumkumji, this is a no-brainer, because the benefits far outweigh, as we have discussed, far outweigh any risks. The risks mentioned of thyroid cancer are easily taken care of by checking a family history. The risk of pancreatitis is exceedingly rare. People with diabetes and obesity are in any case prone to pancreatitis. The risks of eye disorders are still being explored, whether there's anything there or not. Muscle loss is purely because of weight loss and not because of drugs. So I think at the moment at least, unless something really strange emerges, the benefits far outweigh the risks. If you're going to use it, if everyone's going to start using it for a few kilograms here and there and stop it and then take it again before the next wedding and then again stop it, then of course I cannot predict.
I'll take your word on that.
So,
are these injectable or pop a pill like metformin?
So we do have oral GLP-1s like the oral semaglutide, which we have been using for 3 years, but the oral pills at the moment are much less effective. So these are once a week injections.
Okay.
But there's a lot of advance in this area. And as I said, we're just opening up this area. You have data on oral drugs which are not broken down in the gut. So you will probably have oral drugs which are fairly effective, almost as effective as the injectables in the future again in the next couple of years. That's huge, because the moment you talk of a pill, then everyone's attitude changes. It's the injectable that creates, like insulin, that creates a big buzz. So it'll become like that. You also, very interestingly, have research on muscle preserving drugs and fascinating studies which have looked at muscle prevention along with GLP-1 actions, which means that you may actually preserve muscle while losing fat. And the day that code is finally cracked in the clinical sense, that will be another big game changer. So, I mean, I think the field is just opening up. In that sense, you're right. We are researching actively, but
and overall, quick to jump in?
No, I think overall it's much more positive than negative. We hope and pray that nothing negative emerges that sort of counters the positive effects of these molecules that we are seeing.
You know, while on pills, there is a fear of the unknown. And a case in point, of course, I am not comparing the situations, is the death of an actor recently who was allegedly on anti-aging pills. Now, why not then, and I am not saying against this backdrop, but generally, the conservative route rather than the experimental? Eat carefully, exercise, than try new drugs.
So they are not mutually exclusive. You have to eat carefully and you should exercise, no question about that. But we all know, let's take the example of diabetes, which is the best understood, or even obesity, that despite that you can't control it. So you need drugs to help. So same thing happens with weight. With weight also people get exceedingly frustrated, and if the weight is at a level or to an extent that it can cause adverse side effects, adverse impact, it should be fixed. So therefore, I think the conventional route has to be there, but it may not be enough. It is not enough, in fact, studies have shown. And using better tools to help our patients is what we are looking at.
Okay. You know, little is known about GLP-1 drugs, but how grave is the danger of misinformation? What to believe and what not to believe is, and you've also spoken about this in your book.
So I think for me that is one of the biggest fears, the social media. Anyone can post anything. When you search for GLP-1 drugs, you will find two extreme opinions. So you will find one that says these are the answer to mankind's problems. Everything can be solved by these new molecules. And the other end, you will find, oh, this is all a pharmaceutical gimmick and there are too many side effects which are underreported and companies are hiding this. The truth, as always in medicine, lies somewhere in between. These are amazing molecules that have changed the way we look at some chronic disorders, but they are not without their drawbacks, and certainly they cannot be, you cannot pop pills or just give yourself shots without adequate expert medical supervision. So yes, they work very well, but not for everybody. Yes, they work very well, but there can be potentially some downsides. So we need to be aware of that.
Dr. Ambrish Mithal, thank you very much. Thank you for this fascinating and revealing conversation where I must concede I have learnt a lot.
Thank you very much, and your questions have stimulated me to even further simplify for my patients, and maybe some of them have the impression that you brought out so nicely here. So I'll work harder to clarify things to my patients.
Thank you very much.
Thank you.